Do I sound and look okay here?
Yes, and do. I can hear you and I can see you. Thank you very much.
Thank you, Colin.
This is
And
the clerk with a courtesy announcement that this meeting is now broadcast live on YouTube and our web portal.
And Renee, I see you've joined us. I can see
Yes.
you. Would you like to do a mic test?
Yes, good afternoon.
I can see you and I can hear you. Thank you very much. And welcome back, Mike Rogers. I can see you.
Thank you. Mic check.
And
Test.
I can hear you. Yes, thank you very much.
Thank you. I'll go back on mute.
And Laura, I see you've joined us. Would you like to do a microphone test? And Dr. Kenneth Horowitz, I see you've joined us as well. Would you like to do a microphone test?
Yeah, hello, this is Dr. Ken Horowitz.
I can see you and I can hear you. Thank you very much.
Colin,
Yes.
Mr. Mike Rogers will be presenting item number 10. I'll just be listening.
All righty. And he's been back and forth a couple times here, so we've seen him and he's tested it as well.
Okay, great. Thank you, Colin.
No problem. And if there's anyone else that wants to do a microphone test that has not done so already, feel free to jump in now. Other than that, meeting will start in just a few minutes. It's 1:57. And I believe we have Vice Chairperson Lee is here, and we're just waiting on Chairperson Simitian. So that'll just be a couple minutes. Thank you very much.
Good afternoon, Supervisor Simitian.
Good afternoon. Am I speaking with Jess?
You are.
Jess, am I coming through loud and clear?
You are, as is your video.
Thank you. I will,
I have 30 seconds to 2.
all right, I will start us in 30 seconds then. Thank you.
Recording in progress.
All right, ladies and gentlemen, good afternoon. I'm County Supervisor Joe Simidian, and this is our regularly scheduled Health and Hospital Committee meeting, and it consists of two members, myself and Supervisor Otto Lee. So the first item of business is item number 1, call to order, which we will do at this time, but we'll also ask the clerk to confirm the presence of a quorum by calling the roll.
Vice Chairperson Lee. Oh, he was here and it looks like he may have had a technology issue. He's no longer in the room. But he was all checked in.
All right, I saw him as well. Why don't we wait? There he is. He's in his office.
Sorry about that. Now I'm here.
All right,
Chairperson Simidian,
here.
you have a
So
quorum.
thank you. We have a quorum, and that takes care of item number 1, the call to order. That takes us to item number 2, public comment. And let me ask the clerk, do we have anyone who wishes to speak under public comment?
We do not.
All right, then without objection and hearing none, public comment will be deemed complete. That takes us to our consent calendar. And I would be looking for a motion from Supervisor Lee.
So moved.
I have a motion from Supervisor Lee to approve the consent calendar as contained in our published agenda. And I will second that. Let me ask the clerk if we have anyone wishing to speak on the consent calendar items today.
I have no requests.
Then we will call the roll.
Vice Chairperson Lee.
Aye.
Chairperson Simidian.
Aye. And that passes unanimously. All right, that would take us to item number 4. But that item, which is the item to receive the Santa Clara Valley Healthcare report relating to the status of our adult and adolescent sexual assault forensic exam, the SAFE program efforts, is scheduled for a time certain, no earlier than 3 o'clock. So Supervisor Lee, we will come back to that at 3 o'clock. That then takes us to item number 5, which is to consider various recommendations relating to medical staff and allied health professionals at Santa Clara Valley Medical Center, O'Connor, and St. Louis. And let's see who we have with us to present on that item.
I'm Dr. Harry Morrison. I'm the president of the medical staff. I'm here to present the credentials report and answer any questions.
Thank you very much. Supervisor Lee, any questions? And forgive me all, I have put my screen up so I can avoid bandwidth challenges today. Supervisor Lee, any questions?
No issues. Thank you.
All right, can I get a motion then to approve?
Yes, so moved.
Second by Simidian. Let me just check with the clerk, see if we have anybody who wishes to speak on that item.
No requests.
All right, then we will call the roll.
Vice Chairperson Lee.
Aye.
Chairperson Simidian.
Aye. Motion carries unanimously. Thank you, Dr. Morrison. Your work here is done.
Thank you.
Takes us to item number 6, which is recommendations relating to the Child and Adolescent Behavioral Health Services Center. And let me just ask who would like to present on this issue?
Good afternoon, Supervisor Smitty and Supervisor Lee. Doug Koenig, Deputy Director of Capital Programs. I only have one update to the report, and that's that the contract with WebCore to build the new facility is complete, and it's with WebCore for signature. Are there any questions?
Mr. Koenig, excuse me, it is in what status regarding signature?
I'm sorry?
I said, excuse me, the contract is ready for signature or has been
Yes, it
signed?
is. The contract's complete. We've reached agreement. It's been assembled, and it's with WebCore for signature.
Okay, it's with WebCore. That was the word I did not pick up. Thank you. All right, and any estimate as to when it will be signed and returned?
But they are as anxious as we are to get that contract executed. I would expect to get it back today.
All right. And we have your report, but just so I can get a contemporary, up to the moment assurance, when do we think we're actually going to start construction, or WebCore will start construction? I know we've been working on the demolition and the site prep that another contractor is performing.
That's correct. Webcor's contract calls for them to take over on February 1st of next year. The current contractor is on schedule. He expects to be done by February 1st. They are coordinating closely together to make sure that they are ready for a smooth handover, and they're actually trying to add a little work into the demo and excavation contractors scope so that things that could be done now will be done now, and Webcor will be that much ahead when they get started on the 1st.
Great. And then been a little back and forth, as you know, on the completion date, both and everybody looks at a different one, but construction ends when, staff and stock ends when, people walk in the door when. What's your current understanding of that? I'm looking at packet page 61. Just want to make sure I understand it correctly.
Yeah, no change from what we reflected last meeting.
All right, let me put you on the spot then and say, which means construction, as I look at the page, ends on July 16th of 2025, and staff and stock ends September 1st of 2025. Is that still right?
July 16th is the temporary beneficial occupancy date. And that's the date that allows, at which time they will allow staff to go in and start the staff and stock.
Okay.
So
Dr.
there's
Smith,
expectation.
go ahead, Mr. Koenig. I didn't mean to cut you off. I apologize.
No, that's what I was going to say. That would mean that when they're done staffing and stocking, they would be ready for licensing.
Okay.
And that would be on 9/1/25.
All right. And how long does licensing take? Or is that a question that goes to somebody else?
It probably, I don't know if there's anyone from licensing staff here, but that we will certainly try and go ahead.
Yeah, the Supervisor Simidian, Paul Lorenz. Typically, we submit our application for licensure simultaneously as we're staffing and stocking, so that when we're ready to go, they're able to appoint a time as soon as possible on their schedule.
Okay. Dr. Smith, Mr. Lorenz, Mr. Draper, anybody else? I'm again looking at packet page 61, the construction contract with a 7/16/25 end date now. Is that still your best estimate?
I think that's the best estimate at this point. My understanding is Webcor is anxious to get going and anxious to complete it as fast as possible. Obviously there are always unexpected eventualities, but at this point, 7/16 seems to be the best anticipated time.
All right, thank you. Mr. Draper, Mr. Lorenz, anybody else?
Nothing from Jeff.
Thank you. Supervisor Lee, any questions or comments?
Thank you, Chair Simidian. Yeah, I'm very excited to see that the demolition of the existing parking structure 3 is now 100% completed. And I'm glad to hear that this contract with Webcor is now finalized. And these are obviously very important milestones that we haven't been able to accomplish previously. I do want to ask, can the administration provide a bit of a breakdown of the funding sources and amounts to support the construction of the new building?
Sure, we can do that. Yes, well, I'll just talk. I won't give you the amounts right now because I don't want to give them off the top of my head, but we did sell bonds, lease revenue bonds, for the majority of the cost. And we also then have used some general fund for subsequent costs. So, and we have money from the state, the behavioral BSIP, behavioral construction money. So we patched it together with basically 3 sources. We'll get you the numbers.
About 80 million, right, Jeff? Is that correct?
I'm sorry?
The BSIP, I think, is about $80 million, correct?
Yeah.
Yeah, good. Okay, very good. Thank you. And that's all I have for now. And very, very glad to see that this thing's moving very quickly. Oh, one more thing is, I do see that the parking structure 4 is getting finished fairly quickly in the next 4 months. I don't think it would matter really much to our ultimate deadline here, but anything to update on that one?
No, I think as far as the parking structure goes, they actually, the schedule was extended 29 days due to discovery of the asbestos and the fireproofing for the steel beams. But that's well underway.
Yeah, but Supervisor Lee, it's Jeff Draper from Facilities and Fleet. I believe the schedule you're looking at is 2024, not 2023.
Oh, I'm sorry, 24 April. Sorry about that. Okay, yes.
Okay.
So that's another year from now. But anyway, so that the completion of that really has no bearing compared to what we need to finish with Webcore, correct?
Correct.
Okay, good. All right, that's all I have. Thank you very much.
Thank you, Supervisor Lee. The 2 requested actions under A and B on item 6 are to receive the report. Can I get a motion to receive the report?
So moved.
I will second. Let me check with the clerk, see if we have any public speakers on this item.
Have no requests.
All right, then call the roll, please.
Vice Chairperson Lee,
Hi.
Chairperson Simidian.
Aye, thank you very much. That takes us to item number 7, which is to receive the report from Public Health Officer relating to COVID-19. And do we have anybody from Public Health? I know we just talked about this at our board meeting two days ago, so.
Yes, good afternoon, Supervisor Simidian and Supervisor Lee. This is Dr. Cody. And, you know, the status is fairly similar to where we were Tuesday. Interestingly, with our wastewater, we're seeing a little bit of a downturn in some sewer sheds, notably the Palo Alto one, but it's of course difficult to know whether this is the downturn of a sort of sawtooth going up or whether this is the downturn of that was the ice pick tip. So we'll just keep watching it. But the top level message is still that there's quite a lot of COVID circulating, and it's time to layer up, use all those layers of protection. Even the CDC community levels interpretation is now the recommendation for masking in indoor settings, higher quality being optimal. So I'm really just happy to answer questions and continue the discussion we had on Tuesday, if that would be helpful.
Thank you, Dr. Cody. My one quick question is just, I'm going to guess that we don't have any greater clarity today than we did 2 days ago about why that spike in the Palo Alto wastewater plant is so dramatic compared or contrasted with others, or do we?
No, but I really, again, I want to emphasize the top level message, which is it's not so much the differences between plants as to see that all plants are trending up and are very high as compared to where they've been at other points in the pandemic. That's really the top level and important message that I want people to understand, because I want people to know that they're really at much increased risk of exposure, and it's time to take measures to protect themselves.
All right, thank you. Supervisor Lee, comments or questions for Dr. Cody and her team? I'm sorry, Supervisor Lee, you're muted.
Oh,
there we go.
Thank you very much. Talking to myself again. Thank you, Dr. Cody. So on the wastewater review that being conducted, besides COVID, does it able to look at RSV and the flu as well?
Yes, the RSV trends that I showed at Tuesday's board meeting actually were RSV from wastewater, and those look like they have plateaued and are now beginning to drift down, although not reflected in hospitalizations just yet. Similarly, we have flu data from wastewater that is on the public health website. There's a flu dashboard. It includes wastewater data. Right now, I believe it's just influenza A, but as you may know, there's both influenza A and B, and we are collecting influenza B and just right now trying to figure out how to best represent both so that the public can see kind of what the overall flu trends are. And I can tell you the trends are, they're going up.
Right.
There's a lot of early
And-
flu activity.
Right. And when somebody gets sick with one of these three things, can they be getting sick with two or all three at the same time?
It's certainly possible to have co-infections, infections with more than one. So because you got one doesn't mean that therefore you won't get another. You can still get another as well.
Right. So if that's the case, and you said that the numbers basically on the wastewater is been basically almost or as high as ever since the beginning of COVID. Is it safe to say that basically COVID is practically everywhere at this point?
Yeah, I think that's really the take-home message, is that there's a lot of COVID circulating. I think the question is, this year is different than last year's in that we have a much higher level of immunity in the population, both from vaccination and prior infection. And so understanding what the impact of it will be is, we'll follow along. But the sort of the top level message really is that there's a lot of COVID circulating, which means that the chance that you might get exposed is pretty high. And the hospitals are already feeling stretched, not just from COVID, but from flu and RSV.
Right.
So those are really the main messages.
I mean, it's really a very sad message or negative message in the sense that, well, COVID's all-time high, and then you have on top of it, you have the flu and the RSV. So it's almost like a guarantee that you catch one or the other this season. And with less people wearing masks right now, as we have seen, like in public transportation, or just go outside, right? Less and less people are wearing masks because of fatigue and whatnot. I'm just so concerned that our hospital beds and ICUs are ready for the potential surge on these numbers.
Right. Well, as you know, each hospital has a surge plan, which depending on the activity, they may implement some or parts of it. But the important message, even 3 years in, and I understand that nobody wants to be where we are, but here we are. Right? Nobody wants to be here, but we don't have control over a lot. But we do have control over our risk to ourselves. And I honestly think that the best thing that people can do in addition to getting vaccinated is put on your mask, really important inside, put on your mask, because no one wants to miss out on work or school or holiday gatherings. And we saw the big spike after Thanksgiving, not surprisingly, right? Folks come together and gather for Thanksgiving, and then the spike is right after that. So, we of course understand that emotionally everyone has moved on, but we do need to pay just a touch more attention and get our masks out again.
Well, with the holiday season coming up, not just for the specific Christmas holiday, I mean, right now I just look at my calendar. There's so many events going on in the evenings. Lots of people having holiday parties, and most of these are held indoors. So I think the word would be for people to get masked up, in addition to obviously getting their shots, right? Their COVID shots and their flu shots. Really, masking up is really more important now than ever.
Yes, I think so.
Yeah. Okay. That's all I have. Thank you very much, Dr. Cody, as always.
Thank you.
Thank you, Dr. Cody. Supervisor Lee, can I get a motion to receive the report, please?
Yes, so moved.
I will second. Let me turn to the clerk and ask if we have anyone wishing to speak on this item.
I see no requests.
All right, then we'll call the roll.
Vice Chairperson Lee,
Aye.
Chairperson Smidian,
Aye, thank you very much. Motion carries unanimously. And thank you again, Dr. Cody and your team. That takes us to item number 8, which is to receive the report from the Santa Clara Valley Healthcare Organization regarding the progress of our workforce mental health efforts and the well-being of our workforce. Who's going to present on this item, if I may ask?
Hi, Chair Simidian Paul Lorenz again. Supervisor Lee, So joining me actually in this presentation, I believe John Mills is present along with Gina Donnelly. And as you know, Supervisor Simidian and Lee, during our last conversation around this topic, the most important aspect of what we can do around employee wellness was to improve our EAP services in support of our employees. And I am going to ask John Mills to present what ESA has done, not only for the health system, but for the entire county.
Yes, thank you, Paul. John Mills, Employee Services Agency Director, Chairperson Simidian, and Vice Chairperson Lee. Just a brief summary of some of the information that's presented in the report regarding the county's new EAP provider Concern. As the committee might recall, the board approved a delegation of authority to administration on October 18th to enter into a contract with Concern. And that contract was expeditiously executed and services commenced on December 1st. Services are accessible 24 hours a day, 7 days a week through a network of 960 providers within Santa Clara County. 90% of routine counseling referrals are offered an appointment within 5 to 7 business days, and 100% of urgent calls are offered an appointment within 24 to 48 hours. Concern also provides critical incident support, as well as support with financial, legal, identity theft, dependent care, stress management, sleep, time management, and other work-life balance concerns. The county anticipates receiving quarterly and annual utilization reports from Concern, which will give us a snapshot of the types of services that employees are accessing, how often they are accessing those services, and we'll be able to make year-over-year comparisons of utilization trends. So this is a tremendous benefit that we're able to offer to our county employees. It will drastically improve accessibility to employee assistance services for our employees. And we're very proud that we were able to implement it so quickly after the delegation of authority was granted. And on that note, I just want to, be able to thank Gina Donnelly, who's also on the meeting. She was very instrumental in working with the vendor and labor relations and working with our labor partners, the employee benefits department, procurement, and the county council team who worked with us to get this all in place in a matter of a few short weeks.
Thank you very much. I will have some questions, but let me turn first to Supervisor Lee and see if he has comments or questions.
No, thank you. The thing is the contact with Concern. I believe that has been executed, has been used, correct?
Yes, it was executed and services became available to employees as of December 1st. So we're 1 week into our arrangement with Concern.
Okay. So if going forward, we will be collecting data on, how often the service being used and assessing the improvement so that the employee engagement and well-being is being monitored, correct?
Yes, that's correct, Supervisor.
Okay, great. Thank you. That's all I have.
Thank you. Mr. Mills, let me just ask, how will the county review that? How will the county assess and review and respond to satisfaction on the service? Tell us a little bit more about that if you can, please. And if you want to phone a friend and pull Ms. Donnelly in, please do.
Actually, I would like to pull Ms. Donnelly in because she has had quite in-depth conversations with the vendor about how they provide services and how they engage with their client agencies. So I will defer to her to speak.
Thank you.
Good afternoon. So I think, there's going to be two components. There's certainly going to be the measures of success in the utilization reports and getting data reported back to us in terms of how quickly, if they're meeting all of their performance targets, essentially, if everyone's getting an appointment within at least 90% of the contacts within 5 to 7 days, if we're meeting that target. And if we're not, finding out where is the breakdown in the services. I think the other component of it too is really making employees aware that if they are having trouble receiving services or aren't understanding how the process works, that they can reach out to our ESA service centers, and the staff there knows, it has been educated about how the program works and should be able to troubleshoot any issues. And certainly those can, if they can't resolve them at that level, they can certainly elevate them all the way up to John and I.
How are you feeling about the awareness of our employees that these services are in fact now available to them since it's just started up?
I mean, its initial kickoff, I think went very, very well. We were able to do a presentation. We actually had some of the staff from Concern come and speak at the meeting at the bridge last week. We followed that up with an all countywide email, which also contained a flyer that we requested that staff, supervisors who know they have employees that don't regularly use county email, that they print those out, make them available in break rooms, put them on poster boards and things that they have up in their office for ease of communication. We are planning a second communication to go out next week, sort of as we get into the holiday swing, and which along with that, of course, comes holiday stress, to kind of remind people again about the benefit through a newsletter that is published by Concern Health.
Well, as one member of the board, I will just exhort the organization to do everything you can to make sure that the availability of the resource is understood throughout the entire organization. I don't, at the risk of stating the obvious, you know, it's only as good a service as it proves to be in use, and it won't be in use if we don't spread the word. So I want to encourage that continued effort and suggest that perhaps when you think you've done everything you can do, you look for another thing to do. That's my request as one member of the board. And then let me just ask, is there a sort of a regular formal monthly, quarterly time when you sort of either you individually or some team of you sit down and say, okay, let's stop and take a look at how this is working and whether or not we're getting what we bargained for and what we think our employees need?
So we will be receiving quarterly utilization data. And that's just aggregate data. It's all, there's nothing in it about who is accessing the services or anything. So that will give us an opportunity to see, you know, if there's certain areas where there seems to be more prevalent access, which could just be because those are people who are, you know, more stressed out, because it's, you know, if it's, we might see an uptick in, you know, our, you know, granularly, if we get down to collecting data as far as like what department somebody works in. Of course, some of that we have to collapse down because we wouldn't want to inadvertently identify someone. But to the extent that we can say, oh, look, in, you know, in March, you always see an uptick in usage in the assessor's office because that's a really stressful time of year for them, something like that. We might be able to access some of that data. I think the areas we'll be more concerned about are the areas where we're not seeing a lot of activity, and then figuring out how we can outreach and push information out to those departments. I think one of the things we're also planning for the first of the year is a roadshow with Concern Health for our managers and supervisors, because really those are our eyes and ears out in the field, and they're going to be the ones who would first identify if maybe an employee is struggling and would make sure that they at least identify that the benefit is there for those folks, and then they can choose whether or not to access.
Got it. Let me, and Ms. Donnelly, I don't know if it's you or Mr. Mills or Mr. Lorenz or somebody else, but would it be possible, say, on a quarterly basis, perhaps a month after you receive the data or at the next HHC meeting, you know, after you receive the data, to share a report with our board, with our committee, the HHC committee? We would probably typically expect it to be a consent calendar item just to receive the report. But I do think, you know, at least for the coming year, it would be nice over the next 4 quarters to feel like we had a handle on, you know, the rollout and whether or not people are taking up the opportunity and whether or not the metrics are being met. Thoughts about the best way to do that?
I think your suggestion would work if we get it on the next agenda a month after we've had the data. I think initially it's really just sort of baseline data for the first 2 quarters. I think it's going to take some time before we'll be able to see trends. And but again, understanding what that baseline is and where we're starting and then being able to see our progress will be important.
Yeah, if we could get as part of that report, and I'm going to ask Supervisor Lee to offer a motion in a minute that says receive report, provide direction, and presumably the direction would be to come back on a quarterly basis after you've had the data for at least a month, with a report which would go on consent unless it was pulled off consent, sort of assessing, here's what we got and here's what it means and here's what we should be happy about and here's what we should be concerned about. That's a long rambling motion, but that's roughly what I'm looking for. Does that sound doable?
I think so. I think it's going to, it'll be a learning experience for all of us since this is a new contract and an expanded benefit. So I think all of that will be very interesting, and certainly to see how the trend goes as the word gets out about the program.
Thank you. I think, again, one supervisor's view, I think we have all had occasion now to observe just how widespread the impact of managing through the COVID years has been. I don't pretend that any of us fully understand it, but I think we really can't deny that it has had impacts on our workforce in ways that are frankly sometimes hard to imagine or fully appreciate. So I want to say thank you. I'm very appreciative of the fact that folks have jumped on this and have moved with some speed to put the system in place. And now I want to make sure we do our work to assess and improve as need be over the course of the coming year. So with that, I'll turn to Supervisor Lee, see if he has any other comments or questions. If not, can we get a motion to receive the report and provide direction as indicated by the chair?
Yes, just wanted to thank John and Gina for the report, and no further questions, so moved.
All right, thank you. We have a motion by Supervisor Lee. I will second. Let me check with the clerk to see whether we have anyone teed up to speak on this item.
I have no requests.
All right, then we will ask the clerk to call the roll.
Vice Chairperson Lee.
Aye.
Chairperson Smidian.
Aye. That motion carries unanimously. Thank you all again. And we look forward to hearing from you on a regular basis as indicated and directed. Thank you. And that takes us then to item number 9, which is to receive the report from the Santa Clara Health System relating to options for improving mental health care access for West Valley residents. This, I think, is a referral response rather to the referral that we put in the hopper back in October. And Dr. Smith, who would you like to have present on this item?
Yes, and good afternoon, Mr. Chair Smidian and Vice Chair Lee. My name is Rene Santiago. I'm Director for the County of Santa Clara Health System, and here with me is also Dr. Sherry Terrell. We wanted to, obviously, within a short turnaround of less than 2 months, we wanted to give you a progress report. So it's not a full completed report. And we wanted to recommend an approach to see whether, in fact, this is hitting the mark or not. In the written report, what you'll see is we're recommending what we call a hub and spoke approach, since we're planning, of course, to have the ANZA Comprehensive Primary Care Center on campus. That would be the hub that would not only provide preventive, but also primary care services for the surrounding communities, as well as the student populations. Part of that comprehensiveness does include mild to moderate mental health and behavioral health services. That is our plans going forward. What we're also proposing is some major goals as part of this approach. And then, of course, the spokes that will link the identified needs and populations that we can plan for to the necessary services that are available in the community. Now, what you have as part of your attachment is really what we did based on my direction is we cast a wide net. And then, of course, as you know, in fishing terms, when you cast a wide net, sometimes you catch some fish and sometimes you catch a variety of different things. So some of those lists that we have given you is outdated. So we're going to have to do a deep dive because, as you know, recently under COVID, a lot of the care has been disrupted. Many of these sites have gone either obsolete or are no longer operating, or they're operating as part of the telehealth services they're providing, or in some cases they were merged into larger organizations. At least a few of those cases we have identified. Most importantly, and especially given the discussion that we had on Tuesday, when we talk about behavioral health and specialty mental health services, we have to be very clear about, okay, is this something that we do directly as part of our core mandate in terms of the specialty mental health services? Or is this something that is done by the Medi-Cal managed care plans as part of the mild to moderate? So, of course, when you cast a wide net, we catch, like I said, a variety of different sites with a variety of different capacities and a variety of different scopes of services. So what we're recommending as part of our next step is to really take a deep dive, to really do an assessment of what capacity truly there is in this community. We know there's almost 89,000 Medi-Cal residents, as you indicated in your referral. By taking a look in terms of our current data systems, we know we have directly served about 5,000 of those residents for a variety of different behavioral health services. Correspondingly, we have to assess what really capacity is there in that community. Are these sites that are still open and available? And if they're available, are they on site or are they available by telehealth? And if they're available for primary care, or are they available for specialty care? So we're recommending an approach to help us do that. Obviously, we'll begin with the contracted sites that mental health has right now. That is the most, quite frankly, contemporary and current list of the specialty mental health network that we operate in those communities. Then we'll be supplementing that with our Valley Health Plan network, because as you know, under your leadership, you asked us to expand not only access to 650% of the federal poverty level, but you also asked us to implement parity so that people up to that level can experience access and convenience of a variety of different services, whether it be on the medical side of the house as well as the behavioral health side of the house. So we'll be supplementing our core list with VHP's list. And then, of course, we're going to be asking our partners, both our FHP, our local public local initiative in terms of the Medi-Cal managed care plan for mild to moderate, as well as Anthem Blue Cross, which is the private, to supplement that list and really give you a sense in terms of what's available. And then as the last step, we have to survey, and we have to not only conduct a telephonic survey, but also on-site survey to see what level of capacity they truly have. In many of these cases, as you know, when we talk about private networks, it's really an individual practitioner that's a therapist or clinician that's available. They may have a closed panel, so they may not necessarily be available for new clients. In other cases, they may be available for new clients. So that concludes our report, and we're certainly open to any questions you might have.
Thank you. And if I have bandwidth issues again, we'll shut the system down. Let me know. Mr. Santiago, thank you. I have, I think the hub and spoke, as you call it, is you know, a sort of a helpful and sensible, you know, way of thinking about this, model, if you will. But two obvious concerns are that, and I appreciate, I should say, the fact that you're taking the long view on what it's going to take to serve this area. But, you know, if we can get a West Valley clinic sited at the De Anza location, and I'm pleased that you're anticipating that happening. So I take that as a plus, just to be clear. You know, that's I don't know, 3, 4, 5 years away realistically. So again, pleased that you're sort of thinking about this long term. On the other hand, that means that, you know, for the next 4 years, practically speaking, we're going to need to find a way to provide stepped up level of service to an area that is underserved, in my judgment. And you know, as I looked at the list of providers that was attached to the report, I don't know, it looks like there's dozens there. It was, I thought, important not to draw from that a sort of a false sense of comfort, because I think, you know, there probably are only 3 or 4 of those providers that actually serve the West Valley, because it's, you know, my district. I'm attentive to that, and, you know, glad that many of them are there for the North County, but they're relatively, you know, less than a handful that are probably, you know, truly present in the West Valley. And of that group, some of those I think are exclusive or primarily focused on serving younger patients, minors, which is service obviously that's important and we want more of that as well. But so all of that is a sort of a long introductory way of saying, both in the near term, when, you know, we're not going to have a clinic at De Anza, and, you know, God willing, and the Board of Supervisors approves it, we will eventually. But both in the near term, when there is no hub for the spokes, and then long term, you know, we're going to need to develop these. What do we need to do? And if you want to come back to the full board in 2 months with a plan and say, here's how we step up our contracts with nonprofits, it sounds to me like you're saying that the primary solution, both near term and also so we have some infrastructure in place long term, is to ramp up our partnerships with nonprofit providers out there in the community. Did I hear that right?
Well, that would be the most immediate, obviously, opportunity that we would have, is to be able to, as part of our capacity assessment, is to identify what are the partnerships, because many of these sites, as you probably already understand, is they're partnership sites where we're out stationing a therapist, for example, a therapist or a clinician that's available for the community, and they may not necessarily be there full time, so they might be only on a very limited basis. So we really need to understand that, first of all. And then secondly, of course, is how we can actually begin to expand that capacity, so that in fact, because we know we have ongoing clients in that community. So to the degree that we can identify those immediate opportunities. Now, of course, I would have to consult not only with Sherry and her team, but then also with Dr. Smith in terms of what that would translate into. But I couldn't give them a sense in terms of both whether it be funding or resources, other resources, until I really get to understand what capacity it's truly available at this point.
Does another couple of months give you that opportunity?
Yes, I think obviously what we'd like to do is, given your heightened interest on this particular issue, and we could do it in February, so we can come to the February HHC and then the subsequent full board meeting to give you not only more better and accurate data, but then also to identify those immediate opportunities to go forward.
You mentioned Ms. Terrell, and who so far has been delighted that I haven't pulled her into this, I'm sure, and Dr. Smith. Dr. Smith, if I can pivot to you for just a moment and say, what is the budget timing connection here? I want to make sure that the timeline that I'm sitting here chatting with Mr. Santiago about is in sync with whatever we need to be considering in terms of resources through the budget process.
Yeah, we won't have a problem with the budget because we have the opportunity at mid-year and then an opportunity before and after and during the fiscal year 23 budget process. So I think the rate limiting step right here is understanding what the numbers are so that we can get some concept of cost and come up with some source of funding.
Dr. Smith, thank you. Does that mean that if bluntly put, in layman's language, I'm just concerned we're going to miss the boat for the June budget adoption in 2023. Want to make sure that doesn't happen, because then even if you're, open to trying to find an opportunity for these issues to be addressed, anything that's out of calendar is out of calendar. If we have a meeting in February in a couple of months at HHC with a report out to the full board at the first meeting after HHC in February, does that give you enough time to address whatever concerns you think you can address in the June budget?
Yes.
Okay, thank you. Then Mr. Santiago, back to you, and thank you, Dr. Smith. Mr. Santiago, back to you. I think that's the timeline I'd like to be working on if we
Will
could.
do.
And then let me just check in with Mr. Rao, who, as I say, I sort of jokingly said she's managed to escape the questions so far. But Mr. Rao, anything you want to share in the way of input before I go to Supervisor Lee and see if he's got comments or questions?
Thank you, Chair Smitty and Supervisor Lee. Nothing to add other than fully supportive of the plan that Mr. Santiago laid out, and we will certainly come back in February and provide that information.
All righty. Supervisor Lee, let me turn to you. What I'm looking at now is what I think is a follow-up report, meaning a second report at our committee in February with a set of clear recommendations to be forwarded to our board in March, and then consideration of those recommendations as necessary and appropriate in the June budget process, which of course begins before June. That's where I've left it over to you, Supervisor Lee, for comments and questions and perhaps a motion to that effect.
No further questions. I'm ready to move forward as stated.
All right. So we have a motion by Lee and a second by Simidian to receive the report. Thank you again, Mr. Santiago, and to ask the folks here in the committee to come back to us at our next HHC meeting in February with an update and a little more robust plan for implementation based on a fuller understanding, and then present at the first meeting in March immediately thereafter. And I know sometimes our calendars can be a challenge at the board meetings. Is March this year the one where we only have one meeting this coming year?
Yes, March.
Oh,
That's right.
Yeah, then that's the meeting we wanted at. Okay, so if there's only one, let's have it at that one and make sure we get it done so that it can then be folded into our budget process. Motion by Lee, second by Simidian. Do we have any speakers on this, Madam Clerk?
we do not.
All right, then let's call the roll.
Vice Chairperson Lee,
Hi.
Chairperson Simidian.
Aye, and that measure carries unanimously. Thank you very much. And that takes us then from that item to item number 10. And item number 10 is the item on functional medicine. And who would like to present on that?
Mr. Chairman, this is Mike Rogers from the Health Advisory Commission. I'll present. Let
Thank
me
you.
turn on my screen sharing for a brief slide deck. Moment. Okay. I'll get started. The Health Advisory Commission has worked for 2 years on endemic.
Sorry, Mike. One more click. I think we're not seeing your presentation.
Let's see.
We got a good look at you though, Mr. Rogers. Not to worry.
I missed the share button. I clicked.
And you'll want to start from beginning
Okay.
under
We
the
have the
slideshow.
technology now. Thank you, supervisors, for your time today. The Health Advisory Commission has worked for 2 years on endemic.
Mike, I'm so sorry. I'll need you to hit slideshow and then start from beginning. We're seeing the 12th slide right now.
Wow. Okay. Let me stop the share. Share screen. I'm gonna do the whole screen. and then do it this way. Now, do you see the title slide?
Yes, I believe so.
Okay.
Yes.
Thanks again for your time. We're trying to be concise here and cover this in a reasonable amount of time to not waste your time. The Health Advisory Commission has worked for 2 years on endemic chronic disease and functional medicine. Today, we propose a referral be made to the full Board of Supervisors to initiate a discovery team to define a pilot for integrative medicine with functional medicine services in the county health system. We've developed this proposal with input and feedback from Renee Santiago, Dr. Hui No, and Michelle De La Calle from the county health system. Chronic disease is overwhelming our population and our health systems. Incident rates of these chronic diseases continue to explode faster than we can forecast them. Chronic disease is now endemic and ubiquitous across the U.S. populace, even among pediatrics. This drives unprecedented decline of U.S. longevity, which has monotonically declined for each of the last 6 years and is now declining faster than ever, the worst among OECD countries and falling further behind. Chronic disease is already 75 to 85% of our total U.S. health costs today and growing. This is neither sustainable or scalable and threatens to completely overwhelm our health systems and budgets, let alone the health outcomes of our county residents. When we look at whole person care, it uses the lens of the social determinants of health to assess and take care of all the SDOH environmental issues around the patient. These include housing, transportation, logistics, daycare, access to food, as well as access and affordability for care and medication, as well as behavioral health. So what is functional medicine? Functional medicine is a specific discipline within integrative medicine. Integrative medicine is a larger conglomerate of holistic medical services that can include acupuncture, naturopathic, chiropractic, and other services. Neither are currently embodied in the county health system. Functional medicine is a metabolically focused, technical, and analytical extension of whole person care. It leverages individualized patient-centered assessments and mitigation of root causes of chronic disease with a focus on nutrition, gut health, and insulin and energy biosystems and the underlying insulin resistance common to the chronic and inflammatory disease epidemics. Its clinical goals are primarily nutritional, but also focus on key lifestyle and medication adjustments towards optimal health outcomes and regression from chronic disease. Functional medicine and metabolic health MDs have achieved improved outcomes across a wide range of chronic diseases, improving outcomes from diabetes to obesity, heart disease, dementia, and even behavioral health issues. The appendix of these slides lists 49 contemporary leading technical references on chronic diseases and studies from leading institutions like Stanford, Harvard, UCSF, Johns Hopkins, MDs and PhDs successfully using functional medicine and metabolic biosystems approaches to mitigate chronic disease. So this is how functional medicine builds upon the patient-centered experience of whole person care. Once whole person care has taken care of the most basic SDOH needs, functional medicine coordinates between and partners with primary care services and public health interventions, providing additional assessments and individualized guidance within the whole person care domains of home, kitchen, environment, and lifestyle domains like nutrition, stress, rest, and exercise patterns. Functional medicine is generally highly reimbursable under Medicare and Medicaid CalAIM as it directly treats the leading chronic and complex chronic disease states. Many of these are among the higher reimbursable service types within CMS, with many CPT codes at EV2 or EV3, that is equivalent value reimbursement schedules. So the value proposition for functional medicine is simple, powerful, and multidimensionally win-win. One, close the equity gap and make these services available to the diverse parts of the county that need them most, as PAMF, Kaiser, Stanford, UCSF, and others already do. Two, start to achieve better health outcomes for chronic diseases among the less affluent and more diverse ethnic segments of our county residents that suffer from them the most, a key reason they suffer the highest rates of COVID infections and severities. Three, lower health costs for individuals and for the county by actually improving people's health. A metabolically optimally healthy population leaves more beds and services for those in need, potentially begins to mitigate county health costs currently running at $4 billion per year and approximately 1/2 of the county's budget. Now, in the value proposition, this slide shows the equity gap a little more specifically, the breadth of integrative and functional medicine services by other local and major U.S. healthcare delivery systems that are not currently offered within the county health systems and clinics. This slide is a small snapshot of a recent study published in August 2022 showing remarkably improved outcomes and lowered prescription costs, leveraging individualized metabolic nutrition, education, technology-assisted monitoring, and care plan management, which after only 24 weeks yielded substantial per patient weight loss, A1C reduction, and $4,000 per patient prescription cost reduction within the overall lower cost Mexican prescription marketplace. So we've been developing a draft of what a functional medicine pilot might look like by talking with local functional medicine and metabolic medicine MDs, academics, dentists, dietitians, as well as eminent leaders from Stanford, UCSF, and the Osher Institute in San Francisco. We will spare you the details on this draft slide and jump to what would be needed to make a pilot successful. We will say, however, we strongly feel pediatrics should be included, as doing so can affect lifetimes of health outcomes and health costs, as well as start to grow generational learning for the future. As an output of our discussions with the county health leadership, we generated this list of required elements for success. We need plans to develop awareness, nurture education, and obtain buy-in of both the health, provider, and patient communities. We need to nurture and build executive support to drive consistent resourcing. And ultimately, we need to nurture a wider culture of integrative and functional medicine in our county health system to be successful. We also need to verify and continuously improve the reimbursement models. What we're proposing today is that the Board of Supervisors charter a discovery team and process to sort out more thoroughly specific plans for the initial pilot. Such a pilot and program cannot be successful without succeeding on each of these elements. The discovery team will be responsible for not only specifying a pilot, but also for detailed plans for each one of these elements of success. This slide describes some of the preliminary thoughts of how a discovery process could best be organized and best approach defining a pilot, awareness campaign elements, and plans for integration into the county health system. We'll spare the details of these preliminary thoughts and jump straight to today's request. This is our formal request from the Health Advisory Commission to the Board of Supervisors via the Health and Hospitals Committee. We recommend a formal referral to the Board of Supervisors to initiate a functional medicine discovery process within the county health system to complete definition and specification of a pilot and awareness program to the Santa Clara County Board of Supervisors via the Health and Hospitals Committee, and also to return to the Board of Supervisors once the discovery team has developed specifics for a successful integrative medicine, functional medicine pilot and awareness program. This concludes our presentation. We'd like to especially thank legislative aides Matt Savage and Daniel Cow for their ongoing feedback and time. Thank you.
Thank you. Let me turn to Dr. Smith or some member of his team to be identified and get your take on what I hear as a request for some official authorization and direction to begin a discovery team discovery process, which would potentially lead to a pilot project, which would potentially lead to something more. Dr. Smith, your thoughts?
Well, I'm always lately thinking about the fact that if the board creates a commission, it's a Brown Act body, which is not really, I think, what the Health Advisory Commission is talking about. We would need to have an administrative group get together and talk about options and review the data, and clearly the medical staff would have to be involved in this, and I don't think the board wants to have that as a Brown Act body for the sake of developing a proposal or a plan. So I guess that's my biggest concern.
Thoughts about how we could allow this notion to get some traction if it proves successful in early consideration? Maybe someone from County Counsel's office wants to weigh in as well, but I don't want to speak for Mr. Rogers and the commission, but I'm guessing they don't really care so much how it's structured as that there is some opportunity to work toward the possibility of a pilot project. Is that a fair summary, Mr. Rogers?
That is correct.
Yeah, I think the best process would be to ask hospital administration to gather a group of experts together and with the Health Advisory Commission or representatives from the commission to review the suggestion and options in science, and then that's most likely to lead to something effective.
Thank you. I'm going to ask if Supervisor Lee would make such a motion.
Yes, certainly. Be happy to support that.
I would second it. Mr. Rogers, how does that strike you as a path?
That's aligned with kind of the feedback in ongoing discussions we've had with Renee and we know in particular, who said, really, we need to get champions for this within the healthcare system. I'm the population health guy, Michelle's the operations. And one of the next steps was to go to the heads of primary care services, to internal medicine, pediatrics, endocrinology, et cetera, and see what level of feedback we have with really good, detailed, analytical backup, well backed up presentation to them about the value of moving forward.
Got it. Let me check with our clerk to see if we have any speakers on this subject in addition to Mr. Rogers from the commission.
Yes, I currently have 2 requests.
Then let's go ahead and hear from both of those speakers. And we, of course, pursuant to our rules, will allow up to 2 minutes for both of those speakers.
Thank you. Our first speaker is Robert Lustig. I've opened your microphone. Please accept the unmute. You'll have 2 minutes to speak. The timer will start when you begin speaking.
Thank you, Mr. Chairman, and thank you, Mr. Rogers, for the opportunity to talk today. I am a emeritus professor of pediatric endocrinology at UCSF. I was head of the obesity program at UCSF for 17 years. I learned a lot taking care of obese kids, and what I learned is that modern medicine is not adept at dealing with chronic disease. All the chronic diseases that children today now get that they never got before, type 2 diabetes, hypertension, dyslipidemia, cardiovascular disease, cancer, fatty liver disease, polycystic ovarian disease, these are the diseases of mitochondria, the little energy burning factories inside cells. The problem is we don't have medicines that go to the mitochondria, that get to the mitochondria. This is a problem of enormous depth and breadth. It is breaking the healthcare costs throughout the entire country. I just came back from Malaysia to consult with them on their diabetes epidemic. They have the exact same problem that we do. The bottom line is modern medicine is trying to treat the symptoms, not the cause. It's like giving an aspirin to a patient with a brain tumor because they have a headache. Might help the headache, not going to do a damn thing for the brain tumor. And that's the way we've been dealing with these chronic diseases for the last 50 years. Functional medicine, integrative medicine address cause, address root cause. We know what the root cause is. It's our diet. And so we have to address that. So in any effort to try to bring a functional medicine on board, you're going to have to bring the dietitians on board, and that's going to be a very heavy lift. Thank you.
Our next speaker is Stephanie S. I've unmuted you. Please go ahead.
Hello, good afternoon, Supervisors Simitian and Supervisor Lee. I am commenting today in a dual role as the board clerk for the Health Advisory Commission and as a private citizen. I've been the clerk for this commission for almost 7 years, and Chairperson Stetson and Vice Chairperson Horowitz are both dedicated and excellent leaders on the commission, and they really do truly care about the community and improving healthcare systems. The ad hoc committee has been working very hard on this project, and I would like to commend them for that, as well as voice my support as a private citizen for the proposal. I really think that a functional medicine program could be very beneficial in numerous ways for the community. And as a private citizen, I think, looking at innovative and accessible solutions to healthcare should always be on the forefront of the health and hospital system and the county as a whole. Two more things. I strongly echo looking at a pilot project with a member of the Health Advisory Commission instead of creating another meeting body. And my final comment is thank you so much for your time. Again, I think the Health Advisory Commission has done a wonderful job on this proposal, and a shout out to the board operations team at Clerk of the Board. Go team. Thank you.
All right, we will consider that an unpaid, unpolitical advertisement. Thank you very much.
Our next speaker is Helen Norman. I've opened your microphone. Please accept the unmute. You'll have 2 minutes.
Thank you. Thank you for the opportunity to speak. Mike Rogers and I have had several conversations about the integration of primary care and public health interventions, looking directly at the social determinants of health, and that the integration of primary care and public health intervention is really the essence of the functional medicine focus. I would also like to compliment Director Santiago on the article that he wrote about the integration of our healthcare system to fight diabetes. So I am working with the Diabetes Prevention and Wellness team at the Public Health Department to write the next strategic plan. Our focus is really on prevention and wellness. And so I support Mike Rogers' request today for a pilot, not only a pilot study, but a pilot project to see how an integrated system would work and how it can be sustainable at both the clinic and community level. So thank you.
And Madam Clerk.
Pardon me, one more speaker. We have the next speaker, Jocelyn. I've opened your microphone. Please go ahead.
Thank you very much. My name is Jocelyn Dubin. I am a registered dietitian of 20 years and an integrative and functional medicine trained dietitian. I'm also a public health nutritionist and want to say from a public health perspective that because the main objective of our strategic plan is chronic disease prevention, we can only get to prevention if we incorporate integrative and functional medicine within our practices. Otherwise, it is a reactive rather than a proactive approach to medicine, which is incredibly costly for the county, as you all are very well aware of at this point. So I also want to really echo from my 20 years of practice and 20 years of really helping patients to use proactivity to prevent chronic disease and treat chronic disease. I really want to echo the sentiments of Dr. Lustig and Helen Norman and others who have spoken and support the work that Mike and his commission are doing to try to really bring forward integrative and functional medicine into our chronic disease prevention approach. And also, it is one of the most powerful things we can do in the name of racial and health equity, which I know our county is very focused on in this moment. Thank you.
And that concludes our speaker requests.
Thank you very much, Madam Clerk. Thank you to the speakers. We do have a motion on the floor from Supervisor Lee, seconded by me. And Dr. Smith or team, anything else before we call the roll?
That's a shaken head no.
Thank you. Then call the roll.
Actually, I just want to say make one quick statement, Chair Submitting.
Forgive me, Supervisor, I did not see a hand up. My apologies.
Sure. So I just want to thank the speakers and also Commissioner Rogers for your hard work on this issue. This is something that I'm extremely excited about, because as we have learned, a lot of times when we take these heart medicines or the blood pressure medicines and cholesterol medicines, we're only suppressing the numbers. We're trying to make the numbers look good. We're not addressing the real cause, and it becomes a chronic situation. The cost is very high taking these medicines. Of course, they have side effects and whatnot. And what you're doing here, what you're suggesting here about this functional medicine is truly dealing with the cause of the issue. And something that I'm familiar with sometimes with the Oriental medicine, some of the alternative therapies that's been done other ways, acupuncturists and whatnot. So I really think it's important that this is something that we can do more, especially if a lot of these ideas and a lot of these treatments are now becoming more and more acceptable and reimbursable as well. So I'm truly excited about this project, and I really look forward to this quote unquote experimentation moving forward, and hope that we'll get some good news so that we can get that integrated into our care plan, to our healthcare as a whole. Thank you.
All right. Now I'll say to the clerk, please call the roll.
Vice Chairperson Lee.
Aye.
Chairperson Simitian.
Aye. Motion carries unanimously. Thank you all very much. Mr. Rogers, thanks for the work that you and the commission have done, and look forward to hearing how you progress. Okay.
Thank you.
Thank you. All right. Because we had a time certain item, Supervisor Lee, I think you will recall that we now are going to skip back to item number 4, which was our 3 o'clock time certain item, and that is to receive the report from Santa Clara Valley Healthcare relating to the status of our adult and adolescent sexual assault forensic exam SAFE program. And I am going to turn to our staff and say who would like to begin the presentation.
Thank you, Chair Simitian. Kim Walker, our program director, is here and will be presenting on this item.
Thank you.
Good afternoon, Chairperson Simitian and Vice Chairperson Lee. I'm Kim Walker. I'm the nurse manager for the Adult Adolescent SAFE program in Santa Clara County. We're here to provide a report since our last report to you in June of this year. Just want to give you a little bit of an update on the number of people that we have seen who have disclosed and reported requesting an exam for either sexual assault or intimate partner violence. In the total of 2022 through November 17th, which was the time of this report, we had seen 804 cases for the adult adolescent patient population, and that's 12 and older. This represents a 19% increase over last year at the same time when we had seen 677 patients total. So our average has increased. Monthly, we've moved from 56 patients a month to 76 patients per month, which, while we aren't fully sure of what is causing the increase, it does comport with what they're seeing nationally. There was a recent article from JAMA that came out that said, in tracking cases across the country, that there has been a steady increase. In fact, there's been a 1,500% increase between 2006 and 2019. And this is primarily those that report to the emergency departments for care. So it's multifactorial, like we've spoken before. The article does point out that there are increased numbers of sexual assault. There is increasing numbers of people coming in to report based on, social justice movements like Me Too and Time's Up. There also are those of us who are able to respond now to the ED in person and help consult. So if there is a question, we can go right out and prepare to talk to the patient about their rights and see if they want an exam in real time. So good news is that since we spoke to you last, we are doing better in approaching our goals for staffing. All of the coded positions that were approved last budget year have been filled, and that includes the 6 positions that allow us to be a 24/7 staff department. And that gives us on-site coverage for immediate response. The nurse coordinators and staff developer, these positions are important as well because they help with call coverage, work on curriculum development and training, and then keep our daily operations running smoothly. We also have a program manager and senior management analyst positions that have been filled. Both of those are instrumental to support our regulatory and data management needs, both for the SAFE program. And one of those positions was recommended by the Harvey Rose report that came out last year. And that position has now been filled to assist with the sexual assault response team committee. Currently, our hiring is focusing on our per diem examiners. Those are the examiners that are filling the on-call backup responsibilities so that we can have 3 examiners on call at a time so that we can respond to patients wherever they respond or wherever they present in the county and be able to respond to them within an hour on site. So they don't have to travel to a second or third location to get care. With respect to our response locations, the VMC campus still remains our operational hub. It is our busiest, primarily due to our central location and because of our proximity to San Jose Police Department and the Sheriff's Office, which provide many of the cases that we do. This location is slated to undergo a remodel and an update to the interior spaces, which has not happened in a little bit. It's still a very confidential, comfortable space, but we want to make sure that we can keep up with other changes that are occurring in other response locations. And so that's due to begin in the beginning of next year. Additionally, in our North County, the safe response at Stanford Healthcare in the ED there continues to follow the same workflow. We've spoken before about concerns with patients arriving at the hospital, and we've been working collaboratively with the Stanford staff there. They've been excellent. What we've done is rather than calling law enforcement first, they call us first so that we can respond immediately, shortening any time to care for the patient. They are still triaged by the staff at the medical staff on site there. It's a quick triage just to make sure there aren't any additional medical needs required. And then we do our exam and provide our care adjunct to that. With respect to the dedicated space that is being built at the Stanford location, the design and review and space planning have been completed in record speed. I have to add, construction is complete. And the activations team there has held kickoff meetings with us that began in November. We anticipated a January 2023 go live for the new space, but there's been just a small setback with the state coming in and being able to do their walkthrough and inspection. And so I just want to make sure that that is just of no, that had nothing to do with Stanford, that had everything to do with the state, because Stanford is, it's amazing how fast they've got this done, quite frankly. But we look like we are going to be opening first patient day early in February next year. And then last is our South County response. That is going to be at St. Louis Regional Hospital. We are preparing for a December opening, but similar to Stanford, the state is delayed in getting the inspection done. So it looks like it might be pushed to an early January opening instead, but it's just right around the corner. So we will be responding in all 3 locations. And important to note that the EMS destination policy has been changed so that if a patient is transported by EMS, they will be taken to Stanford Valley Medical Center or St. Louis so that we can also reduce the number of times a patient has to go to an outside location and take a second trip to get to us. So that is kind of it in the overview. I have Andrea Bellini with me. Certainly Allison Kerr is here too from Stanford, and we'd be happy to answer any questions that you might have.
Thank you. Before we go to comments or questions from committee members, let me check with the clerk to see if we have speakers on this subject.
I have no requests.
All right. We have no requests.
I'm sorry, I have one hand up.
One hand up, then let's hear from that speaker. And as our rules provide, we will allow up to 2 minutes.
Our first speaker is Erica Elliott. I've opened your microphone. Please accept the unmute. You'll have 2 minutes to speak. The timer will start when you begin speaking.
Good afternoon. My name is Eric Elliott, and I'm the Sexual Assault and Prevention Program Director at Community Solutions. I've been in my role since 2012. When I first started here, we were extremely lucky to have a South County Forensic Safe Exam satellite program that was run out of the Valley Health Hospital. In 2013, our nurse unfortunately retired from the program to go back to her family and other needs she had. And since then, we have not had staffing to be able to provide safe exams in South County, which means that survivors in South Santa Clara County and San Benito County have to drive 45 minutes to over an hour plus one way to receive any kind of medical support for satellite for forensic exams. This can create challenges for a lot of our survivors that don't feel safe driving to San Jose, may not have the means to that. And if you've ever been in South County, you also know that the transportation to get to San Jose takes extremely long because we don't have quality transportation. So I'd really like, and I know that the county really stepped up in 2019, 2020 to help fund the extension of the SAFE programs and extend to build out new programs at Stanford and in South County. But we have been waiting for 3.5 years to have the St. Louis site open. And I'd really like to have some oversight and an expected deadline to have that happen, because we have been waiting patiently through numerous pushouts. So anything that we can do to support that would be kindly respected and helpful. Thank you.
Thank you. Any additional speakers, Madam Clerk?
No.
All right, thank you. Then let's bring it back to our committee and see if we can make a little more progress. And thank you. First, thanks to all involved for the progress to date. I just wanted to clarify, Ms. Walker, the dedicated site as opposed to designated site. That dedicated site, it has been in use for the last several months, even though it hasn't been fully finished up or not.
Are you speaking at Stanford?
Yes, forgive me.
So the space that will be dedicated is fully under construction. It's been completed now. We had to finish that before we would be able to use it, and then it has to be inspected for patient care or for patient use. We have had dedicated space in the emergency department with all of the requirements met for a dedicated interview room, dedicated exam room. So we have everything we've needed, but it's not been in the construction area due to risk. And
I just wanted to make sure, and again, if you think I need clarification or correction, please provide it. It had been my understanding that after we had raised this issue of designated versus dedicated space, that we had in fact made the transition to a dedicated space, so that the concerns about a designated space had been addressed, understanding that the dedicated space still needed an upgrade, particularly the shower function. And you're telling me, I think, that yes, we did make a transition to a dedicated space, and now we're going to make a transition to the, I'll call it, fully upgraded dedicated space once the last round of reviews are undertaken. Do I have it right?
yes, they've been very generous in making sure that all of our requirements are met.
Okay.
They being Stanford.
Then still on the Stanford site, it sounds to me like you're feeling hopeful, optimistic about your ability to keep adequate staffing levels up. Is that a fair summary on my part?
Yes, it's been very robust, and we have a dozen trainees right now that are going through and almost through the process. So we have enough for 3 deep in our on-call schedule, and then maintaining operations as well at all sites.
And then again, on the Stanford site, one of the concerns was that there was still a need to, make your way through the receiving area, if that's the proper term of art, at the hospital there before getting to a dedicated site, understanding that the dedicated site was the biggest of a number of issues raised. I know you and your team were going to undertake efforts to try and make sure that folks who were sort of in the front line of receiving and responding to patients who presented there, survivors who presented there, were worked with appropriately and sensitively. How have those efforts gone, and is that an effort that will continue, understanding that there will be personnel changes over time?
Yes, so we've done our training with all of the emergency departments. We have scheduled training. We plan to do that in January ahead of the opening so that everybody can get questions answered, and that the updated training workflow will be provided to all of the staff. So working with their manager and their director to make sure that we get that scheduled ahead of the opening.
Thank you. And Ms. Walker, I'm literally, given the way my screen is deployed, going to go over your head now to Paul Lorenz, just to say I want to share, and we've shared this before at the committee level, and Mr. Lorenz, I know you know this, but I just want to express my concern that we make sure that the trainings and the orientations continue, on a regrettably never-ending basis, because there always will be turnover. There always will be a need for folks to have their understandings refreshed. And it's just too easy on an effort like this to sort of say, there, our work here is done. And I think while we may be closer to being able to say that with some of the physical infrastructure, in terms of the human infrastructure in the SAFE program, I just want to exhort the organization and the folks at Stanford to keep the trainings and the refreshers top of mind as we go through all this work. And just, if you let me know that you heard that loud and clear, that'll be good enough for today.
We absolutely share your concern and the priority around staffing, resources, and training, et cetera.
Good, thank you. Thank you for that. Thank you for the work that's gone in to get us this place. So back to Ms. Walker. Ms. Walker, did I infer correctly then that we think by February, we really will be able to say we've arrived at the right place in terms of the physical infrastructure?
Yes, that's what I understand.
And then the other area where you have been focusing some attention in terms of training and outreach has been with folks on the campus who are not part of the hospital infrastructure, but are part of the university organization. Presumably those efforts are continuing and will continue indefinitely, given the turnover again and the need for refreshers, even for those who've been present.
Yes, and that work is separate from the hospital, obviously, because the university is a separate entity as far as our training is concerned and all. So we've been, we actually have a scheduled with Vaden coming up to help train with their providers as well. So
And
yeah,
excuse the interruption, you may want to let everybody who doesn't know about Vaden know what Vaden is.
Vaden is the student health center on campus. It's who see the students primarily.
Thank you. All right. And then as to the South County, I guess I have two different but related inquiries. One is you heard the plea for some accountability and a conclusion that we can really count on. Can you give us a date, do you think, that's real and that we can tell the community, you know what, we're really going to have it handled by this date?
So as I understand it, the state has up to 60 days to come in and do their inspection there. So that clock has already started ticking. They could be here tomorrow, or they could be here, at the end of that 60 days. So that's really what's limiting us at this point.
All right. But as you understand it, come hell or high water, we ought to be done by the end of February. Yes.
Yes.
Okay. I'm I know that because of our conversations over these last couple of years, I really am wanting to see us feel, like we have gotten to the right place here. I think a thing that is intangible, but that is clearly important in terms of survivors who have obviously been significantly traumatized is, for lack of another term, the aesthetics of the operation, the venue in the South County. I hear that it is a space. I've not had a chance to visit that space. I have obviously visited the one at Stanford Hospital. I hear that it's a space that perhaps could use some help in terms of creating a less institutional setting when folks arrive on scene after being traumatized. Thoughts about that? And I can't believe it's that expensive. One more thing to add to the list.
Yeah, that's an easy fix. And there are plenty of partners that would be able to help and would like to help with that, including, input from even the speaker. So we have a lot of supportive partners who will have opinions and interest on how to make it a very trauma-informed, welcome, calming space. So that should not be an issue.
Mr. Lorenz, okay with you? Any logistical difficulties if when we receive the report, we provide that direction from the committee as well?
We would welcome that direction.
Yeah, I sense that you're mindful of this already, but if formal direction from the board would make it easier to engage partners and solicit support, I think that would be to the good all around. All right. I will have one more thing or two to say before we wrap this item up, but let me go next to Supervisor Otto Lee for comments and questions on this item. Supervisor Lee.
Thank you. Thank you. First question I have is regarding the numbers of the increasing cases of survivors here. What exactly are we doing to improve the efforts in the sexual assault awareness and prevention moving forward?
There are a number of things. We're going back to in-person trainings, so particularly with law enforcement and the SART partners, so that we can answer questions, help identify patients in their encounters to make sure that people aren't being missed, making sure that they know where to go in a timely manner so that they can get to the fastest possible care. But as far as what's increasing, again, it's a number of issues, and training on that is going to be dependent on what the issues are that we can find locally. But certainly we want to make sure to know that people are aware that we're here, what we can provide, why urgent access to medical care is important, particularly around HIV, pregnancy, if there are internal injuries based on, non-fatal strangulation or other issues that might not be immediately apparent, but would be something that could be very detrimental to their health and well-being if they don't come in and see a provider quickly. So we are looking at creating, in addition to outreach, looking to create videos so that people have resources available, especially like in the ED. So, remember I got that training, but I need to remember, what those steps were, so they have access now to videos that are available to them. We're also looking to develop kind of a comprehensive information package that will make access and other important information available not only to survivors, but to friends and family of survivors or those that are getting the disclosure. And then all the responding partners and potential examiners who may even want to come in and do this work. So by having that all available and also packaging it so like university campuses, we're looking at already talking to Stanford about maybe kind of assisting in that development that other universities could use as well. So there's a lot of conversation about how best to get this knowledge out, because just the iterative training, to Supervisor Smitheen's point, people leave and the attrition happens, and so goes the knowledge with them. So we're trying to figure out how to get that robustly in place so they can have access to it.
Okay. What type of data or information do we need to collect in order to better understand these reasons of the increase of the number of cases and survivors? I mean, if we're talking about like more cases of like people spiking the drinks at parties, or I don't know, some of these things being collected or analyzed?
One of the things that we're doing right now is in developing a database. So we are turning our our paper forms into an electronic version so that all of that data now will be accessible, and we can track it in various ways. So we can look at, the age of the survivor, or the known or unknown suspect, or the time of day, or the location, and then number of injuries or type of assault, all the different ways that we can look at the data and see where the trends and gaps are. So that's one thing we're doing right now, and then kind of merging that and working with other regional and state agencies to see what trends they're seeing.
Okay. Yeah, I mean, I don't know if it's more of a issue on campus, for example, the various campuses, whether it's in Clara University, Stanford, or other campuses like San Jose State University, do we tend to have higher number in those situations, or is it in other areas as well? I certainly would like to be able to find out and then try to target the possible potential cases in the future and try to educate the students, for example, on those issues, right?
Agreed.
Yep. About the South County issue that was raised. So the report on page 4, thank you. Page 5 or 6 there, that talks about St. Louis is preparing for a December 2022 opening. So that's very exciting. How quickly, when you say opening, is this going to be all staffed up, ready to serve the survivors? And how quickly would that be happening? And how many providers are we talking about?
We will be ready to respond there as soon as it's open. It's dependent upon the final inspection and then making sure that the final workflows are all signed off, which we're in the middle of finishing right now.
You're talking about the CDP HXCI AI inspection?
That was for Stanford. This is
Right.
going to be the state inspection.
Is it like an OSHPOSH thing?
Similar, yes.
Okay, all right, good. So as soon as the inspection is done, we're good to go. How many providers do you expect to be provided and how many hours of support?
That'll be the on-call staff that we're training. Right now, we have almost 45 staff and examiners.
Good, okay, great. And the issue that was raised by the earlier speaker about South County, not able to get support, once this is open, that should resolve that issue, correct?
Yes.
Okay, very good. All right, and that's all the question I have. Thank you very much.
Thank you.
Thank you, Ms. Walker. Let me look to Ms. Berlini, see if she's got anything she would like to add. Mr. Lorenz? Nope. All right. And I believe Ms. Carr from Stanford Health Hospital is on with us as well. Anything you'd like to offer?
No, sir, other than my gratitude for partnering with Kim and Andrea and their teams. Thank you.
All right. Thank you very much. And let me just ask Mr. Lorenz and Ms. Walker, I'm going to ask Supervisor Lee for a motion to receive the report and provide the direction indicated with respect to the South County physical space, and want to see if I get a motion from Supervisor Lee. I'm hoping he's going to unmute and say so move.
That's right, so moved.
Got it. And we've worked together for a while now. And I'll say second. And Mr. Lorenz and Ms. Walker, are you clear on the direction with respect to South County and the physical space and the environment and aesthetics there?
Yes, sir.
Absolutely.
Good. All right, thank you. Then we'll check one last time with clerk to make sure that there aren't any additional speakers on this item.
No hands are up.
All right, thank you. The last thing I want to say, well, actually, let me just do one more check-in with staff. We have been meeting on this topic twice a year just to make sure that we are following through. And does that make sense going forward, Mr. Lorenz, Ms. Walker, Ms. Berlini, thoughts?
I mean, we're happy to report. I think that, I'd like to be able to report back and tell you how it's going once we're in all of response locations, and to be able to provide data from the database to see if we can answer some of the questions about why are we seeing higher numbers, or in what areas we're seeing higher numbers.
Let's keep the twice annual reporting structure in place then, just as a way to maintain some transparency and accountability, and ensure the follow-up that I know we all want to see. But why don't I ask you all to work with the committee staff on the timing of that, particularly with reference to the Stanford site. I always, bless you, I always worry that it can be hard to find the right time when folks are on campus and available to weigh in. And I will say that by way of my last comment, which is, I think we have come a long way. Hasn't always been easy, hasn't always been obvious, frankly, what the next step might or should be. But I want to say thank you again to folks in our health and hospital system, and Ms. Walker and Ms. Berlini and Mr. Lorenz, to all three of you who I've been working with on this for a while now. Certainly to the folks at Stanford who, when areas of improvement were identified, stepped up and said, "Okay, we'll take that next step." And perhaps most significantly and importantly, to survivors and advocates who came forward and said, "There's more we can and should be doing," and their voices got heard as they should. So I'm sure there will be more that we can and should be doing, and I think that's why it's important that we continue to have these conversations in this committee venue at least a couple times a year. Clerk will please call the roll.
Vice Chairperson Lee.
Aye.
Chairperson Simitian.
Aye. Thank you all once again. And on our somewhat unusual schedule today, we jump now from item 4, which we heard because it was a time certain, I believe, to item number 11, which is the director's report.
Yes, good afternoon, Mr. Chair, Simitian and Supervisor Lee. My name is Rene Santiago, Director of the County Health System. We submitted again a monthly written report that'll give you updates on critical matters. One particular one that I wanted to highlight for your information is the dashboard that we developed for CalAIM that will give you very specific numbers of people that have been enrolled now in enhanced care management. As you can see there, we're over almost nearly 1,700 total patients that have been enrolled in this new benefit. The overwhelming majority from family health plan. We have teams that are providing the care, and of course, we work through some of the complexities and delays in terms of getting the reimbursement and other supports necessary. Similarly, we have also nearly 400 clients that are also receiving community supports. That's a little bit less number because the community supports have been on a different implementation process, and some of the state and managed care plans intend to phase these in over a certain period of time until they get to the full 14 that are part of the voluntary services, not necessarily a benefit, but it's a voluntary services for clients that are target populations. As part of the approval from and with your support of the delegation of authority, now we can also monitor, but also pursue some very specific funding opportunities with the state of California. There have been some delays in the implementation of some initiatives of CalAIM, and so in some cases, the state is issuing RFPs or directly contracting with counties like ours, with public systems, to go ahead and implement some of the initiatives and projects. And so we wanted to be just as ready as possible to implement those as quickly as we can, so that residents in our community and patients in our system can benefit as quickly as possible. The second part in my report will give you an update on parity. Just to bring you to your attention, the state of California has issued a concept paper to expand community-based services for behavioral health. This would be a precursor to a more formal application to the federal government under the 1115 waiver authority that the federal Secretary of Health and Human Services would have. In it includes expanding the exemption on IMDs, which is an interest of the board, to the mentally ill. As you know, right now, currently, the state does have the exemption on a very limited basis, time as well as size, for the substance abusing population. So our team is looking thoroughly at that concept paper, and will be providing commentary based on your federal policy statements as well as priorities as you express them. So that will conclude my report unless you have any other questions.
I do not. Let me turn to Supervisor Lee before we go on to the next portion of item number 11. Supervisor Lee?
No questions here. Thank you.
All right, thank you. Then that takes us, forgive me, to 11B, which is report from the public health officer. I'm going to assume that we have received that report earlier in the context of the COVID report, which was significantly wider ranging than that. But let me just double check. Anybody from public health would like to weigh in?
No, nothing further to report. We continue to do a wide range of work, but we don't
Thank
have
you.
anything specific to update you on. Thanks.
Just confirm with Supervisor Lee that he got his questions answered earlier. Yes, Supervisor Lee? All right. And then oral report from the CEO at the Valley Medical Center, Mr. Lorenz. I think that would be you.
Thank you, Chair Submitting, Supervisor Lee, Paul Lorenz, Valley Medical Center, as well as the Connor and St. Louis Hospital. I just wanted to just briefly comment on the volume of patients your system is seeing, both in terms of our emergency department at all three hospitals, as well as within the inpatient units. And has been stated and has been clearly articulated by the health officer, RSV, COVID, and flu trends continue to impact your system. We've had record high in terms of emergency room visit volumes at St. Louis Hospital, as well as O'Connor, with Valley Medical Center continuing to see high numbers of patients as well. While we're seeing a clear spike with regards to RSV, flu has been the predominant challenge relative to our patient volumes, both in terms of the ED visits as well as the hospital admissions. I do have to give a lot of credit and kudos to our pediatrics team as they're dealing with RSV, both in terms of the inpatient unit, but also outpatient. We're seeing record numbers in terms of urgent care pediatric visits, as well as demand in terms of pediatric visits in general. And they have stepped up, added additional clinic hours, as well as the weekend, and as well as other access points to ensure that our patients get the care that they need and deserve. But overall, your system is holding up, and we still do have capacity in some respect, but I want to reiterate what the health officer has said. Please take care of yourself, get your vaccinations, both in terms of flu and COVID, and continue to pay attention to what's going on in terms of the impact to the health systems throughout the county.
Thank you, Mr. Lorenz. I'm going to go to Supervisor Lee in just a moment, but I want to toss you not a rhetorical question, but one that I think I hear in different forms from time to time, which is, why is the flu such a big deal this year? We've had the flu around forever and ever.
Well, I can only restate what I've heard from the experts, which is the masking issue. During COVID, people were very clear in terms of their obligation to mask and to not expose themselves to others. So essentially, things have been released into the community. People are less vigilant around that particular issue. So we are seeing greater spread of these respiratory types of conditions. So thus RSV and flu.
I see Dr. Cody is still with us. At least I hope she is. Her screen is up. Dr. Cody, can I pull you into this conversation for a moment, please?
I am here.
Thank you so much. That being said, layman's observation would be, well, people weren't wearing masks 5 years ago. We were used to flu. Was sort of a running annual conversation you and I had about the importance of me getting off to get my flu shot at Health and Hospital Committee. So, do you have a reaction as to why, flu is so daunting for the system this year?
Yeah, I think it's the everything in combination problem. It's the viral soup problem. It's having COVID and flu and RSV all at the same time. Because usually during a flu season, we have flu and we might have a little bit of this and that, but it's really primarily flu. And it does tax the hospitals, in bad flu years, no question. But I've never seen something like we have now, where we have 3 viruses sending our residents into hospitals.
Got it. All right. Thank you both. And Ms. Lorenz, if you'll stay with us, I saw Supervisor Lee had his hand up a bit ago. Supervisor Lee, your comments or questions for Mr. Lorenz, if any?
Yes, thank you so much. Question for Paul is, and I think that's what Dr. Cody has alluded to, is the triple effect, right? With the RSV, we got the flu, and then you got COVID. And these all have very similar flu-like symptoms, right? So when they come in, I guess my question here is, with this triple issue that we're seeing, do you see a not just increase on numbers of hospitalization, do you even see a longer stay on these patients than before, because of the fact that we're dealing with 3 viruses instead of 1? Or do you see that is fairly similar to the regular stay for most of the patients?
Supervisor Lee, I am going to have to defer to a health care professional. I'm not sure if Dr. Fong Nguyen is on the line. I'd like to defer to her if she's available and to comment on the lengths of stay. There's Dr. Nguyen.
Hi, good afternoon.
Hello, good afternoon.
Good afternoon, Supervisor Lee. From the hospital perspective, we are not seeing a prolonged or increased length of stay at this time.
Good. So at least they're not staying longer. But currently, we do see that more folks are being hospitalized, and certainly our occupancy rate is definitely very, very high at this point. That's correct?
Yes, Dr. Supervisor Lee, I think part of the distinction we also want to make is that there are patients who are admitted for COVID, for example, or with COVID, and there's patients that are admitted for RSV, and there's patients that are admitted incidentally and have RSV, and the same thing as well for the flu. But definitely we are seeing a rise in influenza admission, a rise in COVID admission, and the number of admission for RSV is not trending down yet, but it seemed to be plateauing.
Right. Now, do you see patients that has more than one, like, of the 3, you have 2 or 3 of these different viruses all in the same time, or usually only one at a time?
Supervisor Lee, I believe I don't have the specific number, but we did see a couple of patients that has co-infections, but not a huge number.
Not a huge number. Oh, good. That's very good. And obviously, to prevent any of that is what exactly I'm doing right now, is wearing that mask. Is one of the ways to prevent it. And I'm wearing it just to try to model it for the public, something that I keep reminding people to continue to do during these difficult times. And I guess the other question I did ask Paul earlier on Tuesday, Dr. Nguyen, would there be a need of oxygen for treating any of these type of patients moving forward? Because I know there were need of oxygen for treating COVID patients, for example, early on for some of the more serious situations. With RSV, of course, respiratory related and flu, do you see that there will be a need of having the supply of oxygens to treat these patients?
So the answer is yes. For any respiratory pulmonary infections, there's always going to be patient that going to need oxygen supplement. And the hospital team has been doing a fantastic job with monitoring the supply and making sure that we have oxygen supply, but also all the tubings and other paraphernalia that we need to provide the oxygen support for the patient as well.
Good, good. So I just want to make sure that we are on top of the logistics side of making sure we have sufficient supply of the oxygen in storage. So just to make sure we don't potentially run out down the road if things gets worse, if the patient loads start increasing even more.
Yes, we are, Supervisor Lee.
Thank you. I'm just reading what's out there, right? So Orange County has declared RSV as a big crisis, and I read in the LA Times that the LA County supposedly is having issues as well now with some of the flu-like illnesses. I think everybody's got lumping of all the different all those three things, and even Sacramento is also seeing similar trends. So I'm seeing that these larger counties are all reporting very similar numbers, and with our numbers increasing where we are, I just want to make darn sure that we are really prepare for the worst, right? As we are entering with the holiday season, right? We have lots of parties that we're going to, a lot of indoor things, people are celebrating, gathering together. It's a perfect, shall I say, soup of these flu viruses, indoor, people gathering together, eating, celebrating. So I just want to make darn sure that we are really getting ready for this, because the unfortunate thing is, as much as we tell people to go get the bivalent shots, try to get the flu shots, I mean, you know, we've been preaching to the choir. Those who got it already got it, and those who haven't gotten are not, you know, fearful enough to get it. So I think that's what I'm concerned about, and making sure that we are going to be very ready for this down the road.
Yes, and in addition to wearing masks, this week is actually hand hygiene weeks.
Yes.
So definitely, I think frequent hand washing, you know, like masking, and just be safe, get vaccinated. Those are things that we can do and we have control of.
Right, and I'm trying to do the same thing on my holiday greetings I just recorded a few minutes ago before this meeting, to spread that exact same message about masking, washing hands, and getting the shots. And I asked this for Dr. Cody before, is we try to use incentives previously, whether it's boba drinks and cards and whatnot. I just want to double check to see if there are any other things that we could do, any creative things we could do to try to encourage people to get those shots that you can think of.
I just want to highlight that our pediatric team at VMC has done a great job with, you know, like connecting with the patient, with the family. I think they've done some creative solution from the patient, from the clinical care perspective. I can't think of any other thing that we could do, but just send the message, explain to people how important it is, and really that you don't want to get infected, because you can get very sick and you can end up in the hospital and intubated and be in the ICU for extended period of time.
Exactly. All right, thank you very much, Dr. Nguyen, and thank you very much, Paul, as always.
All right, thank you very much. That takes us to 11D, which is the report from the Director of Behavioral Health, Ms. Terrell. Anything you would like to share with us?
Good afternoon, Chair Simidian and Supervisor Lee. You have our written report, and just given that we had a very full discussion on Tuesday at the full board, I don't have anything else to add verbally at this time.
All right. I have no additional comments or questions. You're right, it was a very thorough conversation on Tuesday. Supervisor Lee, anything else before I move on to our CEO at the Valley Health Plan?
I think everything we need to cover, we covered on Tuesday. Thank you very much, Dr. Terrell.
Thank you. Let's go to Ms. Rosas then, who is the CEO of our Valley Health Plan, and see what you would like to share.
Good afternoon, Chair Simidian and Supervisor Lee. You have our written report. One point that I'd like to make is we are still in open enrollment until the end of January for Covered California. Given all of the illness, I think it just really highlights how important it is to get covered. The new subsidies this year are really generous. Many people will only pay $1. They've tried to fix also the family glitch that made people ineligible if their family member had coverage. They fixed that. We think that will provide coverage to another 400,000 people in California. So please look into Covered California.
Got it. Thank you. Supervisor Lee, any questions?
Nope.
All right. Mr. Santiago, are you still within the sound of our voices here?
Yes, I am.
Thank you. And you're quick on that unmute button. Good for you. I wish I were as effective there as you are. You will recall perhaps that early on in my tenure on the board, and Ms. Rosas, thank you for prompting this recollection. You and I talked, Mr. Santiago, about the importance of increasing the percentage of folks in our county who had some form of health insurance. Correct. And of course, when for whatever reason they don't access health insurance or can't access health insurance, we've wanted to have programs like PCAP in place that would address their needs. We have made tremendous progress, and we're coming up on the end of a calendar year. I'm wondering when, and you know, there's no magic to the times involved, except for my frame of reference, it's when I arrived on the board and started to pursue this as a county supervisor. You know, it's been 10 years, and I'm just curious, when might we be able to look at, if I ask the question this way, you know, what percentage of folks were had some form of health insurance January 1st, 2013, and what percentage of folks in our county have some form of health insurance January 1st, 2023, which obviously hasn't quite arrived yet, but we're a couple of weeks away. So that's a 10-year period. And I feel, and I want to do this in part to give you all a shout out, because, you know, we had help from the Affordable Care Act. Obviously, we had help from Covered California. We had help from Medi-Cal expansion, and we had a great deal of help and hard work from our own county organization in expanding access to these programs. And part of it is simple but challenging is outreach. What if we wanted to, you know, I'm gonna guess we were in the high 80s when I came on the board, and that now we're in the mid pushing higher 90s. But is there a source that you could go to that would give us a way to see how much progress we have made and how much we'd still would like to make after this past 10 years once we hit January 1st? And when would you be reasonably able to bring that to Health and Hospital for a little discussion?
No, absolutely. I think what we could do is give you those numbers. Obviously, the latest ones are going to be estimated because, as you know, we normally rely on the census, and there's a certain sequencing to that. But to the best available information, we'll give you both the 2013, which is what we could normally call the pre-ACA Medi-Cal expansion, and then, of course, the latest. And you're right, we were about 89% at that point in time, depending how you count it and which source of information we used. And our best estimate right now is that we're about 96% total. So, but we'll give you our best accurate numbers that we have, so that we have a real good, both the percentage wise as well as the real number in terms of the impact.
If I said March of 2023, would that be a reasonable time frame to look for that kind of a conversation?
Yes, we'll set it up in the agenda.
All right, thank you. Thank you. And Ms. Rosas, thank you for prompting that memory and the fact that that's another one of those issues that we're never quite done with because the work continues. So much appreciated.
You're welcome.
All right, then that will take us to EMS. Ms. Lowther. Or is it Dr. Miller today? Who's going to present on this one?
Jackie, you're still muted. There you go.
There you go. Good afternoon. We have presented a pretty outstanding proposal on various topics, and we are here to answer any topics that you might have questions on compliance or domestic violence. And Dr. Ms. Miller and I are here to answer.
Okay, let me see if you have comments or questions, Supervisor Otto Lee.
No, at this time, thank you.
All right, Ms. Lowther, Dr. Miller, I think you know, because the board packet went live yesterday, I have two distinct, separate, but nonetheless in my own thinking, related referrals in the hopper for our board meeting this coming Tuesday. One of those speaks directly to the issue of how do we find and train more paramedics, given the pressing need that you've identified. And the other is an effort to revisit an issue that we were about to launch in 2020 when COVID interrupted our plans, as it did on so many fronts. And that is the issue of distracted driving, because obviously if we had fewer distracted driving accidents, we would have fewer calls for service, and that would reduce some pressure on the system. So I look forward to discussing those with you at the board meeting on Tuesday or subsequently, and just want to invite you to engage with my office and me if you have thoughts along the way. Okay.
All right. Sounds interesting. Thank you, sir.
Thank you.
Happy holidays.
Back to you. And otherwise, if we can, Supervisor Lee, I will move on to the next portion of this assembled set of recommendations, which is to receive a report from Custody Health. Dr. Day, are you with us?
Good afternoon, Chair Samiti and Pratima Pandey, Admin Services Manager, sitting in for Dr. Day. Custody Health Services has our mental health monitors in the house this week. We have our report, and I'm happy to answer any questions that the committee may have. I did want to highlight, because Supervisor Lee has asked in the past, this past month, Custody Health Services gave 342 patients the bivalent booster. I know you had asked in the past, and we add that to our report. So I just wanted to highlight that.
Right.
Otherwise, I'm happy to answer any questions that the committee may have.
Thank you. I have no questions. Supervisor Lee, Ms. Pandy did a great job of anticipating one of your issues, I know. Anything else you'd like to ask or share in the way of a thought?
Thank you. So looking at the table you provided, in main jail, we're still close to almost 40% that is actually not vaccinated at the main jail. And I think quite a few of them, we look at the data for over 6 months, seems like those are the highest ones, the people who actually stayed in main jail for a long time, that is actually not vaccinated. I don't know if there's any ways we could improve that number, but I guess these are folks who are just absolutely unwilling to get the vaccine. That's the problem, right?
That is correct, Supervisor Lee. Also, because all the bookings happen at main jail, our statistics for main jail continue to have a very high number of people who cycle in and out very quickly. And finally, also because the very high security patients are also housed at main jail. Many of them, we do our best, but it's up to them to choose whether they'd like to be vaccinated or not. Our nurses and our providers are available at all times and continuously keep educating them.
Right. And I see the same number, actually numbers are slightly even worse for juvenile custody, which I'm surprised, because obviously we don't have too many females. Those are all male, basically, in custody. That we're close, like 40% is not vaccinated at all. And so I guess, I don't know, for the juvenile situations, is this something that we need the parents' consent?
Yes, Supervisor, if they're under 18, we definitely have to.
Okay, so I don't know what we could do to reach out to the parents to say how important this really is. And then the third thing I was going to talk about is Sacramento. So I just read that Sacramento now is required to have masking in all jail and prison facilities. Do we have that masking requirement now in our custody facilities still?
Yes, Supervisor Lee, we never removed the masking requirements. All of us at work, as well as all our patients at all the facilities are still required to mask at all times.
Right, and this doesn't, besides those in custody, we include our staff as well working at the facilities, correct?
Correct, yes. And we're also getting everybody tested every single day as part of a requirement for custody health, for the sheriff's office, and for anybody else that are coming to the jails for any business reasons.
Right, yeah, especially as you know, with RSV, even though they might not be tested negative for COVID, they certainly could carry the other stuff, the flu and RSV still. So that's why masking is still so important. Thank you so much, Ms. Penny, for the information. Appreciate it.
Thank you, Supervisor.
Thank you. And then that takes us to item 11G, which is our report on federal health policy and the budget landscape. And I think, yep, so I see Mr. Margolin ready to jump in. Mr. Margolin, what would you like us to know today?
Well, there are several items to review with you. Let's start with the lame duck session. Government funding runs out on December 16th. Negotiations, as usual, this time of year are very slow and difficult. The conventional wisdom is that there will be at least one additional continuing resolution that'll probably take us right to before Christmas. That's sort of the semi-official capital tradition to take these negotiations right up to Christmas, and Christmas becomes more or less a hard deadline for members of Congress, at least an attempt at a hard deadline. It's likely, in my view, and in the view of most people in DC, that there will be an omnibus appropriations package to fund the government for the full year, that this will succeed. And there are several reasons for that. First, last chance for Democrats before they lose control of the House to shape funding priorities. Second reason, defense hawks, both Democrats and Republicans, want the Defense Department funded at the higher level that an omnibus would provide. Another continuing resolution, CR, would be flat funding for the year, so that's a powerful incentive. Third reason is the appropriations bills contain several $1 billion in earmark funding for district projects, which would be lost if only the CR passed. And just another side note about the power of earmark funding to motivate the legislative process. The House Republicans in their conference recently voted by closed ballot in favor of continuing earmarks through next year. The conventional wisdom was that if Republicans who originally killed earmarks a decade ago reacquired power, they would kill earmarks once again. But in fact, by a vote of 158 to 52, pretty impressive margin, they said yes to earmarks again. And the last reason, which relates also to the Republicans, is even though Republican leadership may grumble about the omnibus appropriation, the amount it spends, McCarthy, the prospective speaker, and other GOP leaders would actually like to have one less crisis to face next year. And if the funding is secured for the year through the omnibus, one less crisis to contend with. A couple of health issues to sort of highlight that are being dealt with in the lame duck. The National Defense Authorization Act was unveiled. The bipartisan compromise was unveiled yesterday in the Senate. This is a must-pass bill. This is the Authorization Act for the Defense Department. It's been negotiated for many months, taken longer than normal. And there's one somewhat disturbing health provision in there and one positive health provision. The disturbing health provision is a provision which eliminates the Pentagon policy which required troops to receive COVID-19 vaccine. Rand Paul and several other Republican senators said they'd vote against the authorization if this wasn't removed, and somewhat surprisingly, at least to me and some others, Democratic leadership made this concession. So even though 98% of the troops are vaccinated, there's a 2% factor that has said no, and they've been, in many cases, pushed out of the service. That policy is going to be potentially reversed. There's also, on the more positive side of the equation, $5 billion for global pandemic preparedness in this defense bill. This money will be spent over 5 years to advance the CDC's global health security agenda, which involves going after public health emergencies in foreign countries, helping foreign countries to deal with them at the outset before they become pandemics. It's very important funding. Other health issues that are up in the air, there's this ongoing request from the Biden administration for $10 billion for vaccines, testing, treatment for the uninsured and other pandemic-related costs. It appears to be going nowhere, unfortunately. Republican resistance is extremely strong. They believe the money is already there in the system, and it's not likely to happen. There are Medicare cuts that will take effect for both doctors and hospitals based upon this provision called PAYGO, which requires OMB to cut funding when other funding is increased without an offset. There's this automatic across-the-board mandatory funding provision that takes effect. $36 billion in Medicare hospital funding is at risk, and the hospitals nationally are organizing to stop that, and that may be mitigated or ended in the final package. And then one final health issue that has bipartisan support is telehealth flexibility in the Medicare program, broad bipartisan support, and there's a chance that'll be included, extension of that in the final package. Leadership changes in the Congress are worth also noting as this new Congress approaches. Bernie Sanders will be the new chair of the HELP Committee in the Senate. This is the primary health policy committee in the Senate. Patty Murray, who currently chairs it, is moving to chair Senate Appropriations. While Senator Sanders has been a strong champion of single payer, that's what he's most known for. And he's also been supportive of the ACA. He's tended to put single payer ahead of the ACA on his list of priorities. The ranking Republican will be Senator Cassidy from Louisiana, very conservative, but an independent thinker. It's important to note that he voted to convict President Trump during the insurrection impeachment trial. He takes independent stands at times. It's also important to note that he was a staunch supporter of repealing the ACA in 2017. He and Senator Graham put together the Cassidy-Graham plan, which was the last-ditch effort to replace the ACA. So Sanders and Cassidy, an interesting pair to watch. And in the House, we have McMorris Rogers, who will be taking over from Congressman Pallone to chair the Energy and Commerce Committee. McMorris Rogers is very conservative, but is also known as being attentive to public policy, a serious policy lawmaker. She represents a Washington state district. Some of her priorities that she's talked about include expanding telehealth, again, a broad bipartisan consensus on telehealth, and she wants to improve home and community-based services. As far as the subcommittee chairmanship is concerned, we don't know who's going to chair the subcommittee on health that Congresswoman Eshoo currently chairs. And we don't know that because as Kevin McCarthy aspires to the speakership and works to get the votes in this very narrowly divided House, he is putting off those kinds of decisions till after the Congress organizes itself. They're not working, they're going to deal with that later. When you make choices about subcommittee chairs, or for that matter, full committee chairs, and where there's more than one member who wants the chairmanship, you end up offending, obviously, the members who don't get the job, and he's deferring all that till later in January. Last point worth noting is that we have a new California Democrat in the House leadership. Congressman Pete Aguilar is the caucus chair, a former mayor of Redlands, now a very powerful member. Number 3 in the leadership. So that completes sort of the federal summary. You had also asked at an earlier meeting for me at some point to talk about Medicare Advantage and ACOs. And I know you plan a more formal presentation in January and you want a written report at that time. If you want to have me briefly introduce the topic today and talk about it some, I'm happy to do so, or I can defer that to January, whatever you prefer.
Because we have a little time today, I'd like to have what I'll call a starter conversation or a starter presentation, really. And I will tee it up this way. I have been struck of late by the number of entreaties I have had from constituents who tell me that their healthcare providers are inundating them with suggestions, advertisements, requests that they consider a Medicare Advantage plan. And understandably, they wonder what's that all about. And then secondarily, I will note that it has become, for whatever reason, a bit of a political hot potato in some circles. So what's that all about, Mr. Margolin? And after you get done, I'll check in with my colleague Supervisor Lee in case he has comments or questions, which I anticipate on the federal front.
Sure. So this introductory discussion it will deal with Medicare Advantage plans and also with accountable care organizations, which are also part of this confusing mix. And what I'm going to do is I'll briefly define what each is. I'll then do a little bit of a comparison to understand how they differ from one another. And then I'll highlight some of the controversy that's associated with them, why people get not only confused, but in some cases very agitated about their growth. So Medicare Advantage is a name for Medicare Managed Care Plans. Medicare beneficiaries have had the option of enrolling in private managed care plans for many decades, but it wasn't until 2003 when President Bush negotiated his big major Medicare reform that created Medicare Part D, the prescription drug benefit, that he also created something called Medicare Advantage, which was a major expansion of these Medicare managed care plans. Medicare Advantage plans are run by private managed care plans, and they offer the same basic benefits that you get as a Medicare beneficiary in fee-for-service, but they, in order to induce people to join, sign up, they typically offer a number of special benefits on top of that. They might offer out-of-pocket maximums, caps, that are better than what Medicare offers. They frequently offer hearing and dental benefits that you can't get in basic Medicare, and other perks to encourage enrollment. They are rapidly growing, and here's a key statistic: in 2022, there were 28 million Medicare beneficiaries enrolled in Medicare Advantage, 48% of the total. The reason why your constituents of late have talked about all of the efforts to encourage them to enroll is Medicare Advantage, like any other managed care system, has an open enrollment period. And that open enrollment period actually just closed yesterday for Medicare Advantage. So on television and in the mail over the last several weeks, last couple of months, there's been this intense effort by the Medicare Advantage plans to encourage people to enroll. Now we turn to accountable care organizations. They share some similarity with Medicare Advantage in that they operate on the principle, sort of a managed care principle, that if you get people to enroll and you have a defined population and you keep that population as healthy as possible, there are savings that can be achieved, cost less money. And the savings can be used by the organization for other purposes, and they can also benefit the beneficiaries who will be able to enroll for less money. There are different ACO models, but the one that typically people think about and that typically is utilized here in California is a group of providers, hospitals and physician groups band together to provide care for a defined population. So these are providers, banding, hospitals, physicians saying, we want to get together and we're going to form an ACO. They receive payment from Medicare or Medicaid for this defined population. And the key for them, why would providers want to do this? Well, the providers want to do this because if they deliver cost-effective care and they achieve savings, they can retain those savings as additional profit. These accountable care organizations were given a major boost when the Affordable Care Act was passed, in the same way that in 2003, Medicare Advantage got its big boost. The accountable care organizations were recognized and encouraged as part of the Affordable Care Act. So now, and given a major boost back in 2010. Key differences, just to try to make this as clear as I can. So accountable care organizations are provider-led. It's physician groups and hospitals that get together and say, we as providers want to organize and do this. Medicare managed care is delivered through traditional health plans. It's plan delivered, not provider organized and delivered. In Medicare Advantage, the one with the open enrollment period that just ended, patients need to affirmatively enroll. You've got to sign up, which is why we have all this television advertising, all this pressure. People want them. The Medicare Advantage plans want a bigger population. ACOs, which currently serve over 400,000 Californians, don't necessarily inform patients directly that they are even in an ACO. And this is kind of the peculiar aspect of them. It's sort of an internal understanding between the hospitals and the doctors. The coordination and achievement of savings is an internal calculation between the providers and CMS. They are required to post in the office that I am part of an ACO. So there's a posting that goes on, notification. But from a patient standpoint, while there is coordination going on, if a patient becomes dissatisfied with the provider, there's no restriction. There's freedom of choice. They just can leave at any time. And the ACOs need to measure quality in dozens of categories. And they need to have a multi-year contract. And CMS really scrutinizes them in dozens of ways to make sure the quality is good. Patients are deemed a member of the ACO based upon their primary care physician. So if your doctor's in one, you can be in one whether you're fully aware of it or not. The Biden administration, and we talked about this a month or two back, Supervisor Simitian, has pursued a program called ACO Reach, which is an expansion of the affordable of these accountable care organizations. And it's designed to bring the benefits of ACOs, because there's a strong body of support for the ACOs, strong support for the ACOs in many quarters. They want to bring ACOs to diverse communities where this coordinated care has not been previously available. Now, what that's opened up, and now I'll start to deal with some of the controversies. Progressive Democrats in the Congress, some of them, not all of them, obviously, some of them have openly opposed ACO Reach because they don't like the idea of third-party management of care without prior consent. Again, people are in, you aren't consenting, and through organizations that are typically for profit, often for profit, not always, but often for profit. This is part of a larger theme on the part of these progressive Democrats and others that Medicare, which involves both Medicare Advantage and ACOs, they really don't want to see these systems, the Medicare system, privatized. This involves private organizations having this much more dominant, much more significant role. And the profits or quote unquote savings that are there is an incentive they'd prefer not to see as part of the Medicare system. In general, it makes Medicare more dependent on privately organized delivery systems. I'll close now with two specific examples of controversies involving the two programs. In the case of Medicare Advantage, there have been reports and analyses and discussions done in recent years about efforts by some Medicare Advantage plans to game the system by adjusting the diagnosis codes to inflate the risk score and therefore promote higher payments. Medicare Advantage has been a more expensive program than many people expected, and this adjustment of diagnosis codes is something that's been somewhat controversial. There's also been a concern, moving back to the ACOs for a moment, again, these doctors and hospitals organizing together, that private equity firms have moved to invest in physician groups, private equity, and then encourage them to form an ACO. And obviously, when private equity is involved, the profit motive is very, very dominant. The Biden administration has attempted to address these ACO concerns by making all sorts of new requirements involving consumer representation on the board and trying to minimize the role of private equity. But by and large, in the end, there's a contingent of members of Congress and members of the public who want a single payer program. Ultimately, they want Medicare for all, and they want it to be government run and government driven, and they are resistant to the idea of this private sector engagement in both Medicare Advantage and ACOs. So that's an opening preview or discussion or as to what Medicare Advantage and ACO plans are and what some of the controversies are. And I'll stop there.
Thank you. Let me first ask that when you come to our Federal Affairs Task Force, with a written document that you incorporate everything you just shared with us, rather than think, well, I already told them that, okay? Because as you can imagine, this is a lot to absorb, particularly orally. I am always impressed by your mastery of the information and the cogency of your presentation, as you know. But I think we're going to need to have it in writing. And as I say, don't feel at all that that's duplicative, please. I did want to just clarify for my own understanding when we were talking about Medicare Advantage. You talked about the fact that savings were retained in the ACO, which is the not the Medicare Advantage, the accountable care organizations. But are those savings also retained in some way in Medicare Advantage? For
Yes. In the more traditional sense of that's how managed care plans operate. They attempt to keep their costs down and provide high quality care, and there's some savings.
So, not to oversimplify, and understanding that there are other pieces to this debate, but really both with respect to Medicare Advantage and accountable care organizations, it sounds to me like we're having the same debate that we had 40 or 50 years ago in this country around, on the one hand, managed care helps control costs, which people think is important for a variety of reasons. On the other hand, it limits individual choice. Is it really that basic when we get right back down to the push and shove, or is there some big piece, not the other arguments, that I'm missing?
No, it's that basic, but I would add on the positive side of the equation for managed care, it also focuses on primary and preventive care. So the managed care has that virtue. Again, these hospitals, doctors, people in the fee-for-service system tended to see people historically at the point at which they were sick. So again, managed care prides itself on its ability to intervene early and keep people well.
And I'm going to reframe slightly. So if I mischaracterize, please correct me. On Medicare Advantage, you were reminding me that the savings are sort of built into the system or internal to the Medicare managed system, but that with the ACO, there is actually sort of a calculated savings retained. Yes?
Yes. I mean, there's calculation on both sides, because on Medicare Advantage, they have to negotiate for the rate, and that involves a calculation. But the ACO calculation seems to be more complex because it involves multiple providers and all these quality measurements. What CMS has attempted to do, the federal agency that runs these programs, is they've really attempted, and they do this in managed care under Medicaid and Medicare as well. They're attempting to mitigate against the risk of under provision of care by having all these quality metrics. Sometimes it works, sometimes it doesn't.
And I did not catch, forgive me, with the ACOs, when you say savings are retained, is it all of the savings or some of the savings, with some of the savings going back to the system, Medicare system?
So I'm not an expert on ACOs, and that's an answer at a technical level that I can't answer today. I'll try to find out the answer. I'm sure that it varies by contract and by state and by type of ACO.
If you could incorporate that in your written materials, I would appreciate it.
Sure.
But the concern, again, among those who have the concern, is that there's a built-in incentive to, quote, withhold, end quote, care or service. Yes.
Built-in, right, and with an eye towards profit. And again, the private equity, in the cases where private equity's gotten involved, it's pretty unambiguous the kind of pressure that private equity would bring to the equation. So the Biden administration has attempted and is attempting to figure out a way to curb the influence of private equity as best they can.
And that segues nicely into my final question before I turn to the very patient Supervisor Lee. On ACO reach that you indicated the Biden administration has pursued as a way to get some of this coordinated care out into the community. It did, as you indicated, generate some concern among some segments of the progressive community. And what did you say the administration was doing to try and mitigate that concern?
So they've done things like they're insisting that 75% the boards of these new ACO REACH organizations are composed of providers trying to minimize the influence of private equity and other factor groups. They want beneficiaries to be on the boards as well. They have a whole series of provisions about they want a patient representative, as I mentioned a moment ago, whole series of structural requirements in the organization of the ACO designed to reduce the influence of private equity.
Thank you. Thank you. Really helpful, Mr. McGowan. As you know, I've been trying to wrap my arms around this debate for some time now, and I feel like I'm much closer to a full appreciation and look forward to the discussion we have in our other venue. Supervisor Lee, thanks so much for your patience. Any comments or questions from you, sir?
Thank you, Mr. McGowan. A couple of questions. So first, follow up on the issue on Medicare Advantage. I've always thought is, without knowing much about it, that Medicare is a good thing and Medicare Advantage is a better thing, right? That's what the image seems to be. Until I start reading about it, about the overbilling and the coding of sicker than the patient really is to bilk the system. Billions of dollars is being built every year right now, and the audit has been horrible. And this number is just only growing from various healthcare insurance companies and all that. Not that we'll solve the problem today, but I just want to raise that. That's my latest understanding of this. And is there any type of legislation there to try to discourage or try to minimize these type of practices?
There hasn't been a legislative fix that's been proposed that's gone anywhere. There have been audits and there have been there's public discussion and exposure going on, and I'm sure that CMS, they have to negotiate with CMS, is doing what it can administratively to crack down on this this overbilling.
I mean, really fraud, right? I mean,
it appears to be. I can't really judge fully how widespread it is, but it's the program itself is a big chunk, I said, of the Medicare program, and its costs are higher per capita than people thought they would be, and this is one of the reasons why I'm quite sure. So there is an effort at an administrative level to crack down, and the exposure is they have to market this to the public, and it is, and I think the efforts to crack down on the exposure in the public probably will have some effect, but it's going to be a long effort, I'm sure, a long-term effort.
Right. Second issue is regarding the EITC earned income tax credit and the child tax credit. Are there any movement to get those extended, or are they going to be expiring?
I'm not aware of any movement that is likely to be successful, but I can't give you a definitive answer on that. There are multiple negotiations going on behind closed door in DC right now that, given the fact there's going to be this big package, it'll move quickly. There could be surprising last minute developments. So I can't totally rule it out, but nothing that I'm aware of that's positive at this time.
The NDAA you talked about, that's being in discussion, which of course have all kinds of stuff besides defense issues.
Sure.
It's all lumped together. Do you see a problem why that would not pass?
I think it's likely to pass because of what this is the result of a bipartisan negotiation in the Senate. And there's so many issues to deal with. They only have so much bandwidth for negotiation. So once they have kind of the framework of a deal, it's unlikely not to pass. But again, there's a group in the House Democrats who are not happy with what the Senate has done. So it's not out of the question that it won't be changed again. But I think it will pass ultimately.
And there's apparently some type of Senate mentions insistence of some environmentally unsavory provisions. I'm not sure.
That didn't get in. As of a few hours ago, last night, when last I reviewed the latest, the Manchin proposal that he wanted to have in Build Back Better, and the deal with Schumer was that it would be handled separately.
Right.
It wasn't in the package as unveiled. So
it's not.
But things change. But just right now, it's not there. That's what I read.
Not there yet. Okay. And this is looking a little bit forward. Now that the Senate's going to have 51 Democrats, which is one more than what they have now, do you foresee that there will be a easier time? Because even though Senate might be easier, but you don't have the House. So what's your prognosis moving forward?
Well, it's definitely going to be much easier to deal with nominations, judicial nominations, administrative nominations. All of that will move much more quickly and better. It's going to, and it's going to make it's going to give the oversight function of the Senate a great deal more teeth, because they're going to have a subpoena power, which they didn't previously had. They needed bipartisan support for a subpoena. On the policy side of the equation, you're still going to need 60 votes on the floor to move something. So things will move out of committee more easily because of a majority of Democrats. But the 60 vote barrier is going to make significant policy progress unlikely because of that. A Republican House and 60 votes on the floor. But in those other two areas, oversight and nominations, major difference.
Right. Great. Okay. And that's all I have. Thank you very much for going. As always.
Sure. Thank you.
Exciting times.
All right. Thank you very much. And Supervisor Lee, I'll look to you for a motion to receive the report on all of item number 11. As we say, thank you again to Mr. Margolin and to everyone who shared their insights on this item. Can I get a motion to approve?
So moved.
All right, we have a motion to receive the reports. I will second. I'll check with the clerk, see if there's anyone still hanging in with us who would like to speak to item number 11.
No hands up.
All right, thank you. Then let's call the roll.
Vice Chairperson Lee.
Aye.
Chairperson Simitian.
Aye. Motion carries unanimously. And let me just confirm with the clerk that that is indeed our last item.
It is.
All right, then without objection, and I'm sure there is none, we will adjourn the meeting, and I wish you all happy and healthy winter holiday, and we'll see you in the new year. Thanks so much. Take care.
Recording stopped.